nice talk. Thank you very much. Dr. Debashish, over to you. Yeah.
Dr. Pandian, you continue, please.
No, you can.
Okay, so let me have the honor of inviting Dr. Vijay Sharma, who is Associate Professor, National University of Singapore, Senior Consultant, National University Hospital, Singapore, and he has been a regular speaker and a fine orator in stroke conferences in India. And he has got a special interest in transcranial Doppler. And so I request him to kindly upload his presentation and start with this presentation. Thank you.
Thank you very much for the invitation. So thank you very much for the invitation. My role was to talk about TCD, and I realized that this is a talk mainly for the residents or young neurologists. I'm not here to say that TCD is a replacement for any investigational modality. The aim is that TCD is something which gives you a complementary information. TCD is something which gives you a real-time information. It is something which gives you a bedside information. It gives you a master in the choices. It also helps you in choosing what should be the next set of investigations. And in the next 20 minutes, I will try to just infuse some kind of enthusiasm in the young neurologist to think whether to take TCD as one of their arms in the pocket. Whenever you want to use, you can use it. And if you don't like it, just leave it alone. It's a very easy technique to learn. It's not something difficult for neurologists because you understand what is the brain's blood circulation. And once you know it, then everything becomes simple. I will just divide into simple, and I'm going to keep it very, very simple and basic talk, staying away from most of the research things. So diagnostic applications, TCD is all about pattern recognition. We are all trained actually to identify human faces. Once we see one face, you don't forget that face. So every one of us, we have a different face. Same is TCD. But TCD good thing is that there are only some type of faces. And once you remember this face, then you know what is happening in the brain. So this is the face of a normal flow, which is a rapid upstroke. Then you have a deceleration, you have a dicrotic notch, and then you have substantial amount of diastolic blood flow in the brain. This is normal. The moment these flow velocities increase, this becomes a stenosis. The moment this becomes massive amount of diastolic flow, this is a vasodilated flow post stenotic chambers. Once you have this kind of flow, which is looking like a normal waveform, but suppressed flow velocity, especially in diastole, you say probably patient is dealing with multiple comorbidities, vascular conditions, cardiac failure. And once you see this kind of thing, this is somebody who is a vasculopath. He is having diffuse disease, diffuse vascular disease, not only in the cerebral bed, but also elsewhere in the body. Sometimes you are lucky enough to see these extremes. Like this is a classical third-year teaching of a pulsus bisferiens in a patient with severe aortic regurgitation. Our brain does not permit a steal. Mostly you don't see this kind of thing, but what you're seeing, you are seeing a double peak, which is because of aortic regurgitation. And because it's severe, you see almost disappearance of blood flow in the diastole. Or you can see this pulsus parvus et tarda, slowly rising pulse in severe aortic stenosis seen in both MCAs. So you can identify many of the pathologies once you put the TCD probe on the head. This is what we are taught, that there is a focal stenosis, a short segment stenosis. And what you're going to see is if it's basilar, you are going to see highly elevated flow velocities in the basilar artery. If you see it in the MCA, you see the MCA flow velocities which are increased. And there are different categories, different grades of stenosis which you can determine. Accuracy, especially for MCA, this is excellent. Whatever number you use, whether you are using mean flow velocities or you are using peak systolic velocities, you still have a very good sensitivity and specific parameters. It's a wonderful tool, mainly for selection of patients, mainly for screening purposes. And then you can go on to do the advanced imagings. So this is what we see normally, a short segment focal stenosis. But what happens when you have a stenosis, which is a long segment stenosis? The definition of long segment is more than 1 centimeter in length. Or you have a patient with multifocal stenosis, or you have somebody who is having stenosis multiple in one single artery, or more than one artery. In this case, MCA is having a stenosis, PCA is having a stenosis, bacillus is having a stenosis, other PCA also having a stenosis. So once you have these kind of scattered stenosis, then you don't obey the rules of stenosis that you are going to have very high flow velocities. You are going to see low flow velocities and you are going to see with a higher resistance. So that's a diffuse intracranial disease. This is where you need to be careful when you are using TCD, but it definitely guides you what is going to be most helpful investigation for you if you want to select one investigation. So let us start with how we use TCD in some decision makings. So this is a 69-year-old male, and he just presented with recurrent episodes of right-sided weakness. Every day, multiple episodes he was getting. There was a CT scan initially, which was normal. Then there was an MRI done, which was also normal. There was no acute infarct. And somebody prescribed him aspirin initially, then added clopidogrel and also atorvastatin. And then he came over with another episode on day 3. So now the question is, what do you do next? So you have a normal MRI, normal CT scan. So we did the MRA and we saw it that MRA, there's a severe stenosis in the left proximal MCA. We put the TCD probe, we expected it, we knew it that we are going to see very high flow velocities, but this does not solve the problem. It just says, fine, there is a stenosis. But why is this stenosis causing strokes or TIs in this patient? Simple mechanisms. Either this is artery to artery embolization, or this is hypoperfusion, or more commonly, it's a combination of 1 plus 2. So once you know which is the mechanism, then what you know is what kind of treatment I'm going to give. I'm going to justify that treatment and I'm going to be successful. So you just put the TCD probe, monitor for about 40 minutes. The moment you hear one emboli, which is like a bird chirp, that kind of sound comes, you know you have won the battle. So that is the sound you are looking for, a bird chirp. And the moment you see it, you say, I'm going to escalate my antithrombotic therapy. Whether this is 75 milligram of aspirin or 130 or 150, or you go to 600 milligram or you go to 1300 milligram. Whether you put aspirin plus clopidogrel, whether you are happy with changing to anticoagulation till the emboli disappear. This is the time when you say, I don't respect the patient's lipid levels. I'm going to whack the patient with highest dose of statins, and then I'm going to monitor again that whether the emboli disappear. Emboli should disappear within 6 hours of initiating any of the therapy. If they don't disappear, keep escalating as much as you can, and then you can always withdraw these therapies. Or you can go for other non-conventional treatments, whatever is available to you, whether this is putting a stent there, whether this is putting the patient flat in bed, whether you are increasing the hydration of the patient. Some people say in severe stenosis, just give coffee to the patient, it improves the blood flow and might save the patient from decreased blood flow at that time. It's your choice. You have a lot of choices because you know the cause, what is causing all these problems. But this is a little bit different patient. This is younger patient, female. She has completely recovered from an old subcortical stroke. And now she comes back that she is having early morning headaches. Every morning she gets up, she is having a headache, generalized headache, throbbing in character, which lasts for about half an hour to 1 hour. Once she starts brushing teeth, going here and there, the headache disappears. And the same cycle repeats again and again. She has changed her diurnal rhythm. She is very lethargic, tired in the morning, and she does not have an OSA. Her sleep is good, but she is having these episodes. So again, we are looking at, is it again embolization happening like the previous patient? Is it hypoperfusion? Or again, it's a combination of two. Put the TCD again, it's a 40-minute test. You don't need to sit with the patient. Just keep it recording, keep doing your work, wait for that emboli to call you. And this emboli test was negative. I did it twice. It was negative. So I said, there is no point of increasing any kind of antithrombotic therapy for her, unless I'm going to increase the risk of bleeding. So there's no point of increasing that part. What about hypoperfusion? How do I test that there's a hypoperfusion? Yes, you can do a CT perfusion, but you can predict what kind of CT perfusion or MR perfusion you are going to see in this patient. And that's not going to help. I know that there is a hypoperfusion. So we test autoregulation of brain. We test that is brain able to maintain the blood flow in certain situations or not. You can use, we don't use the manipulations of blood pressure. What we use is simple carbon dioxide. We don't even use carbon dioxide. We just increase the level of carbon dioxide by holding breath or paper bag rebreathing and just monitor. And what you are trying to do is you are trying to increase the carbon dioxide just by 1 millimeter mercury And you know that if it is normal, it's going to increase the blood flow by more than 10%. This is what we learned from patients with severe asymptomatic carotid stenosis for risk stratification. Is it a high risk patient or low risk patient? The moment the number of using this formula goes less than 0.69, you say, I'm going to have a high risk patient in front of me. And this patient is not able to maintain his cerebral autoregulation. He needs other helps from my side. So this is this patient. This is a normal response in the right MCA. Once he starts holding, this is a 30-40 seconds record. You can see the blood flow is increasing because of vasodilation as a response to increasing carbon dioxide. But on this side, what you are seeing is a paradoxical reduction. So this is something abnormal. This is intracranial steal phenomena. The healthy, the strong right MCA through the ACOM and ACA is stealing the blood from the affected side, from the poor side. We call this as reverse Robin Hood syndrome. So this is a Robin Hood which is stealing from poor and giving to rich. But this is the normal life which we see every day. Rich are becoming richer and poor are becoming poorer. So we are following the natural principle of human life. So this is what is happening in this patient. How to correct it? That is the question now. So we tested it and we measured it by using the formula. You can see on the right MCA, it's normal, more than 0.69. Left is going in minus. We don't even calculate in minuses, we just write exhausted. And once you write exhausted, you need to choose the modality of treatment. No antiplatelet, no anticoagulation is going to work for this patient. Unless you have no other choice, you will keep trying. That's the only option. Now you validate, because I can hold breath maybe for 45 seconds, but what happens to my brain beyond that, I have no idea. So you can take the patient for additional investigations, like this is a acetazolamide challenge spec. You can see at normal baseline, there is a little bit of reduced metabolic perfusion in the left hemisphere. But once you give acetazolamide, see, there is an absolute steal. It is almost like 30% steal magnitude. So you know it that if this patient gets a stroke, this is the size of the stroke which is going to be. And this is why this patient is getting up every day morning with headaches, because of severe vasodilation of meningeal collaterals. And once the carbon dioxide is washed out, this patient is fine. We chose to do just the simple ST-AMC bypass surgery indirectly. And you can see it post-surgery, the CT angio shows there's a lot of blood vessels beyond the occlusion remains occlusion, but there are a lot of vessels. We improve the perfusion. Patient symptoms disappeared, never had any TIAs, the headaches disappeared. Breath holding index after three months became normal. I have been seeing this patient for last 3 years. There has been no episode at all. This patient has been only on aspirin, 100 milligrams. We use 100 milligrams here in Singapore. I repeated the SPECT after 4 months, and this is what happened. You see, post-surgery, there is still a residual metabolic perfusion defect at baseline. But what happens when we challenge? No more steal phenomena. And this is what is keeping this patient healthy without having any symptoms. Let us talk about young stroke. A 34-year-old teacher, she was teaching and suddenly she could not write on the blackboard. Lasted for 5 minutes, came to the hospital. No risk factors except she had started oral contraceptive pills about 6 months ago. A brain CT angiogram in the emergency was normal. We did a color ultrasound, carotids and TCD normal. We did the thrombophlebitis screen normal, vascular screen normal. This is the MRI. We just show the typical omega area infarct which was presenting with wrist drop. This is what was causing her inability to write. So you know there is a stroke. But why this patient has a stroke? That's a question mark. So one mechanism is right to left shunt. Now right to left shunt, TCD is empowering you. Don't wait for your cardiologist to tell you. You can do it yourself. You're sitting in your office. This patient is sitting with the head frame. This is a TCD machine. This is the spirometer, which is just measuring how much Valsalva he can do. This is the antecubital vein. There's a plug in it. There's a tri-way cannula, 2 syringes having 9 ml saline, 1 ml air. And just see, I'm going to play this video. These are the 2 middle cerebral artery, which you are monitoring in real time. This is the apical 4-chamber view. This is right atrium. Just remember, black in color. Left atrium, black in color. This is the left ventricle. This is the same cannula. We do this test like this. We shake it about 15 times. 9 ml saline, 1 ml air. Keep looking at the right atrium. When the bubbles appear, see, it becomes white. The bubbles have appeared here. Do a Valsalva here. Nowadays, we don't even do Valsalva. We just test hard on the tummy. We don't use the spirometers. And what you are doing, you start seeing this angle like coming in both MCAs, and you see this emboli coming to the left and going to the left one. TCD helps is you can do it in different body positions, what you cannot do when you are doing an echo. It tells you in lying supine position, very few emboli are coming. Once this patient sits like this, you look at the number of bubbles which have come. This is a high grade shunt, and TCD helps you in determining the functional grading of the shunt. That is the beauty of TCD, that I never refer my patients for TEE if they are negative grade 1 or grade 2. I write a special request that my patient is having a stroke. My only intention is that you tell me that there is no right to left shunt which you see, because this is what my grading is. If you can see it, I'm going to close it if there are no contraindications for it. You can use, these are some of the consensus expert opinion guidelines which we came out last year, which are in interjournal of stroke. Go through it. This just shows the red sign, the blue and the green sign, where you should consider it, where you should not consider it. So these guidelines are available at present. This was one interesting case I saw a few years ago. He is a 58-year-old man, 6 months history of progressively slowing in walking, occasional giddiness, non-specific, occasional diplopia. Again, very difficult to determine what kind of diplopia was that. He had 2 falls which were unintentional. Every blood test, MRI, cervical spine, and everything was normal. We were puzzled what is happening with her till I kept the TCD probe on his head. And I saw that the 2 vertebral arteries are having different kind of flow. Both are going into the brain. Why different kind of flow? This is flowing towards the brain, the left one. The right is flowing away from the brain. This is totally unexpected. And then I saw the pulses, and then I measured blood pressure, and I found there was a difference of nearly 40 millimeters mercury blood pressure in 2 arms. This was a severe subclavian artery stenosis on the right side. And this is the angiogram which we injected into the left subclavian. You can see the contrast going up through the big left vertebral artery. It goes up into the brain. And then what you see is that the contrast has started coming down from the right vertebral artery and then perfusing the right hand. Blood is taking a long time to travel all the way coming to the right hand. But is it causing the symptoms? That's the whole question mark. So I can test it very easily. It takes few minutes only to do the test. Just put the blood pressure cuff on the right arm, inflate to systolic blood pressure of about 30 to 40 millimeters mercury higher than the systolic blood pressure. And then after that, you ask the patient to do this kind of exercise. Do it for about a minute only. Wait for the patient to get tired. Once he says, my hands are tired, don't deflate the cuff, just remove the cuff, because you have to be sudden. And during that time, you are monitoring one of the intracranial arteries, can be vertebral artery, can be basilar artery, can be PCAs. So I was monitoring distal vertebral artery. What you are seeing is this is the flow towards the hand. This is the little flow which is going into the brain during diastole. What happens to him when I deflate? Different kind of blood flow which happens once I deflate. And then you see this patient develops a nystagmus during that time. He becomes dysarthric during that time. And then you say, exactly, I could replicate why he was having all these symptoms. I know the pathology. We did for this patient, this is the surgery done under local anesthesia, CCA to right subclavian bypass. And on the same evening, this patient could run actually, because this was a surgery done under local anesthesia. And there has been no recurrent of symptoms for this patient for last 10 years. I have been following up on this patient. The bypass graft is working wonderfully, and this never steals from the brain. That is the beauty of this surgery. Therapeutic, I'm not going to talk much about it. It is still a technique in development, except the landmark trial showed that you can increase the chance of recanalization in severe cases by nearly 1.5 times. Reviews and meta-analysis showed that it is safe procedure, it's effective procedure, better likelihood of good outcomes. Everything looks good, but we need to prove it in larger clinical trials. But if you're putting TCD, don't think you are doing a therapeutic TCD. Just think what you're doing is you are monitoring what is happening to the artery. You may be the wonderful person to see how the artery recanalizes once your TPA is working. From minimal flow in the MCA, you start seeing in your real time how the blood flow is moving as the clot is dissolving. As the clot is what you see is your patient's hands are moving up. Prognostically, yeah, you can help in not diagnosing, in saying that I suspect a brain death. Brain death is still a clinical diagnosis. All the tests are supplementary tests. Once you see this kind of flow, if you know ICP is a normal ICP, say this is equal to cerebral circulatory arrest. If you don't know ICP, then tell, I'm going to come back after 6 or 10 hours, correct the metabolic disturbances, correct blood pressure. If I see the same kind of blood flow, I'm going to say, start preparing this patient for organ transplant, especially in those countries which run aggressive organ transplant activities. Subarachnoid hemorrhage, TCD was invented actually for subarachnoid hemorrhage monitoring. For vasospasm, I'm just going to see this young patient having this ruptured aneurysm on the left MCA. We coiled it on the same day. This patient's so there was a mild vasospasm, progressed on day 4 to severe vasospasm in both sides. This is what happened to this patient. So this is remarkably different TCD between day 3 and day 6. We said this is the time we need to go to do additional investigations. We did a CT perfusion, shows prolonged MTT, shows reduced CBF. We said now we need to go, and you can see severe vasospasm in the MCA on the left and right both. You increase your treatment, increase double H therapy, give IV nimodipine, and then you can see, wow, how I diagnosed the patient at the right time. I did not allow the patient to progress further because in next day, patients, all abnormalities have resolved. So you have already done all the wonderful works. You can use it for monitoring. The answer is one TCD never tells you that there is a vasculopathy in TB, meningitis, or any encephalitis. Useless, one TCD. If you do it serially, yes, definitely you can say that the vasculitis is progressive, or it is regressive, or your treatment is working or not. You can design your treatment according to what you're seeing on the TCD. Stop trial. If you are living in a belt with sickle cell anemia, it reduces the risk of stroke by 92% if you are using TCD as a criteria for giving blood transfusion. Same, you can do a monitoring. Again, don't do one TCD and say high ICP. Never do it like this. You will be always wrong almost. Say, I'm going to monitor. I can tell you patient's ICP, is it on the increasing trend or is it on the decreasing trend? This is the time of COVID era. We were interested because all our staff members, we are forced to wear N95 masks throughout our stay, and most of us started getting headaches. We said, why are we getting headaches when we started using N95 masks? Because we had this experience from SARS times. We said, we are going to look at the TCD, what happens to my blood flow in the brain. This is my own blood flow in the brain. You see that this is at baseline. Once I don N95, within 5 minutes, my blood flow changes. And this is responsible for my headache. Then when I go to ICU, I'm staying for a longer time, I started using PAPR, and then you can see what happens. When I use N95, all the parameters change in real time, and they are responsible for the headache. So we knew it, that what is changing. So TCD sometimes can be for use for fun also, and you can identify what is causing it. So nowadays, our ICU people who are staying for a long time, they're mostly using PAPRs instead of using just the N95 mask, and they are having a wonderful time sitting there in ICU. So I just want to tell you, it's a very reliable bedside tool. It's a powerful tool. It's reliable for monitoring. For diagnosing purpose, yes, for some condition, it's a wonderful tool, reliable tool. But for monitoring, don't overcall the things when you don't want to call, like ICP I told you, like vasculitis I tell you. So vasculitis may be a stenosis actually there, which you are unnecessarily saying that there's a vasculitis. Monitor it. If it does not change, it is a stenosis. If it changes, in response to your treatment, this was vasculitis, or a new vessel starts showing the stenosis, then this was a vasculitis. Thank you very much. I'll end here.
Thank you, Dr. Sharma, for a very lucid and elaborate lecture. And I think there must be some questions.
Yeah, Devashish, may I ask? Kumar,
yes, please go ahead.
Yeah, Vijay, wonderful talk as usual with you. And what I want to ask is, what is its role of TCD in primary prevention in stroke? Because as per the Hyderabad stroke registry, which we saw that amongst the ischemic stroke, 78% seem to have had an intracranial atherosclerotic disease.
You know,
and what parameters should we monitor when we do this thing in primary prevention?
Okay, so, you know, I can tell you when it comes to primary prevention, you are working on a huge population. That is the biggest challenge. So, but what I do is, because I see a predominantly Chinese population, where the stroke patients, nearly 60% of them, they are having one or the other artery stenosed. Once we see these patients, they sometimes they start even looking like a secondary moya disease. So as a rule, what I do is once I see in a younger patient, I call all the close relatives of this family, especially the kids. And surprisingly, you will find that at least 20-25% of the near close family members, they will show you one stenosis. At that time, there is no indication of starting on any medications. But what you can do is you can do some lifestyle modifications in them. And then I tell them, fine, I'm going to monitor you at least for next 4 or 5 years on a yearly basis, unless you get a symptom in between. And a good proportion of them, they show progression during those 5 years. So that is quite rewarding. But as a blanket cover, that is a very, very difficult thing to do, because again, the challenge will be you can do even on your city basis. One time is okay, but how will you manage it continuously over a long period of time? That becomes very challenging issue. So that is a problem. Otherwise, it's a wonderful tool, definitely, in directed population.
Dr. Sanjeet has a question. Dr. Sanjeet, unmute yourself, please. You're muted.
Yeah, can you hear? Hi, thank you, Dr. Vijay. Just one small practical question. Recently, I had a patient with a condition, and we did a deep showing only a small photo, 1.5.
Sanjay, just take out your speakers and just speak to the thing. That's better. That'll be better volume. Now speak. Don't use the speakers. Take out the speakers from the computers. Try that, because your voice is not.
It's very difficult to understand. Yeah.
Try without the speakers.
Yeah. There's some disturbance.
Otherwise, type your question.
Try without the speakers. Take out the speakers from the computer connection.
Yeah, now it's clear. You can speak. Yeah. Hello.
I think he's typing.
You can
Now
type
we
the
can
question.
hear you. Go on.
Yeah, question is, how can a small 1.5 mm PFO, we had a patient which 1.5 mm PFO has gone and occluded an M1. All the other workup was negative, including full genetic, including genetic. So we knew it was this PFO was the culprit, but we couldn't explain the diameters.
The problem at present is that the indications of closure, they are not exactly related to the size of PFO. There are many other considerations, including rope score.
Dr. Vijay, my question is not the closure. My question is, how can a 1.5 mm PFO cause an occlusion of a M1, which is a large vessel, larger diameter vessel?
It is something like this. People say that once you have a clot, there are a lot of expressions on the clot surface, and every clot has a potential for propagation. Or there is a possibility that there was an underlying stenosis, which was just 60%. A small clot comes, makes your stenosis a complete occlusion at that time because clot got stuck at that point. These are the only explanations. Otherwise, what happens is, because PFO is a very dynamic kind of thing, usually at rest, there are very few people who are having right to left shunting at rest. Most of them, they develop it when they are doing some kind of Valsalva. And it was recorded that, people have a long flight, they develop a small DVT. First thing when they come out, either they go to the toilet and they are rushing. So that's a kind of Valsalva which they are doing. Or they go to the belt, pick up their heavy bag, which involves some kind of Valsalva. And this induces, that clot which was already migrated up into the right atrium, cross at that time. Most of the clots which have been captured, they have been quite big clots, actually, even passing through a very, very small PFO. And then you have to force to say that the PFO was only 1.5 centimeters, but the clot is nearly 3 centimeters. So because clot is not a solid structure, it is still a fragile structure. It could have crossed, it could have been big, and Valsalva just forced it to pass through the PFO. These are the only possible mechanisms, but we definitely extensively evaluate these patients once they have a PFO. We exclude all possible chances of any solid indication for keeping these patients on anticoagulation for long term. If you identify that there's an indication of long-term anticoagulation, then you lose most of the benefits of doing a PFO closure. But if you don't identify, then it's very clear. Close the PFO, which is considered quite a safe procedure nowadays. Keep them on single antiplatelet therapy, double for maybe 1 month, single for 6 months, and then you can stop it by 6 months because endothelization gets completed and there is no more residual shunt which is there. Your patient is free of any kind of antiplatelets for the rest of life. So that's the beauty, once you identify it and you can close it.
Yeah. Thank you.
Thank you.